Thank you very much, Mr. Chairman. In preparing for this hearing, I was looking at some interesting studies and some information to follow up on questions of the relationship between autism and environmental mercury, namely mercury that is airborne as a result of the combustion of coal. The United Nations Environment Program, in a piece called Mercury Control from Coal Combustion, says the burning of coal is the single largest anthropogenic source of mercury air emissions, having more than tripled since 1970. Coal burning for power generation is increasing alongside economic growth. The releases from power plants and industrial boilers represent today roughly a quarter of the mercury releases to the atmosphere. Now, this is from a report called Mercury Control from Coal Combustion. There was a report, actually a study that was done by the University of Texas Health Science Center that showed what's called a statistically significant link between pounds of industrial release of mercury and increased autism rates. The study pointed out that community autism prevalence was reduced by 1 to 2% with each 10 miles of distance from the pollution source. Now, the background of this study was that during the time period studied by the Texas team, they quoted the U.S. EPA estimating environmental mercury releases at 158 million tons annually nationwide in the late 1990s. That's, you know, I'm waiting for more updated figures, but it's probably even greater than that. Dr. Guttmacher and Dr. Boyle, when will, first of all, Dr. Guttmacher, are you aware of any studies other than this Texas study that has created a link between neurotoxic chemicals in the environment and increased rates of autism?
I'm certainly aware of other studies that look at, for instance, the one I mentioned earlier that was just published in the last week, looking, for instance, at auto emissions and proximity to auto emissions in pregnancy and early in life as a factor in terms of a causal relationship, who knows, but clearly an association between that exposure and autism rates.
But they've probably gone down since you've had catalytic converters. I'm speaking,
presumably.
I'm speaking of coal-burning power plants, which are being used and have been used in great frequency over the last couple of decades. Now, are you aware?
I certainly do not know all of the studies in the autism literature. I'd be happy to look into that and provide additional information for the record.
Other than the one from Texas that you're referring to from a couple of years ago, I'm not sure if there's another ecologic study like that. There have been a number of environmental studies that are at the individual level, but not at that sort of population ecologic level.
Well, it seems to me that if not in this Congress, the next Congress, that it would be timely, given the fact that this issue is out there and the amount of coal that has been burned in the last couple of decades, that a study be funded, that we actually look at it and determine whether or not the University of Texas study is confirmed or disconfirmed. The points of this study talk about, of course, exposure, neurodevelopment, the pace of neurodevelopment, vulnerability with respect to age, and also developmental vulnerabilities that begin with pregnant mothers. Of course, genetic susceptibility, as you pointed out, Dr. Gosar pointed out, that's always a factor. But now we know that the amount of emissions may be a factor. That's one of the things that's posited by this University of Texas study. And so, Mr. Chairman, as we move forward with this, because there is inevitably an amount of work that has to be done here that goes way beyond the politics and goes to pure science, or to science, that I think it would be helpful for us to, for the Congress to back a study that would determine once and for all whether the degree to which autism is linked to mercury-releasing sources, specifically the burning of coal, and with respect to the University of Texas study, the amount of emissions and the proximity to those emissions. And I just want to say in conclusion that all these families who are here, you have members of Congress on both sides of the aisle who are dedicated to trying to find out what's going on here and to try to do it in the interest of your family and future generations as well. So thank you for your presence here.
And thank you, Mr. Kucinich. We now go to the gentleman from Pennsylvania, Mr. Meehan.
Thank you, Mr. Chairman, and I'd like to thank Drs. Boyle and Guttmacher for being here today. Let me just start my commentary by saying that as a first-term congressman, we are often impacted by issues that are brought to our attention by the constituents we serve. I can tell you that I don't know of another issue that has affected more of my constituents that have demonstrated a greater degree of frustration than this particular issue. And so it's new to me, and I'm listening to your testimony. But let me ask a question. I know that we saw, you studied this in 2007, we saw 1 in 150 children so diagnosed. And then in 2009, 1 in 110. And now we've diagnosed 1 in 88. So just in this short period of time, and 1 in 54 boys. Have you ever seen anything in which there has been such a dramatic progression in the incidence of diagnosis in a 6-year period in your experience with the CDC?
Well, most of my experience actually has been within the context of developmental disabilities, and we do look at trends in other developmental disabilities.
Has anything had a trend with this kind of accelerating pace?
So actually, there was a paper published a couple months ago looking at the trends in all of developmental disabilities, and the only one that showed an increase was attention deficit hyperactivity disorder.
Talking about at the CDC, we deal with a broad variety of health crises at certain points in time. Has anything accelerated in your experience to this degree in a 6-year period?
Well, again, relative to my area of expertise.
How about in general? You are in the CDC. What do you know about in general?
Right. Well, again, thinking specifically about what's going on with autism, you know, we have been looking at trends over time, and as you point out, there has been an increase. We do know that some of that increase is due to how children are identified and diagnosed in the community. So there have been changes over time that contribute in part. Our system monitors the number of children. We don't have all the information about what's happening in the context that influences how children are identified.
I guess what I'm saying is, and these are your words, not mine, as we've seen this remarkable acceleration just in the diagnoses, and in your words it was, this is a public health concern. Would you explain to me why this is not a public health crisis? Why this isn't an issue that is on the front burner of the CDC every day?
This is a very important issue to the CDC, and we are using the strengths of CDC to approach this issue. We are monitoring what CDC does, and its excellence is basically tracking and monitoring epidemiologic research and prevention.
Dr. Boyle, thank you, because I know what you're saying is you're supporting that has been growing. Dr. Guttmacher, the facts are clear. This has been accelerating at a remarkable pace, at least in terms of the diagnoses. What is being done to have a genuine, comprehensive plan in which we are looking for accountability year to year on the progress that's being made and in terms of what we're doing to better understand this issue?
It's a very important question, Congressman. I think part of it, again, goes back to the IACC having been created and asking for it to every year come up with an updated plan. I can tell you, I haven't checked my emails in the last couple of hours, obviously, but based upon simply the flurry of activity over the last few days alone, there really is work amongst
flurry
multiple...
because of our hearing, or flurry just...
No, because it's that time of year. We're aware that the year is coming to a close, and really trying to put together this year's plan in a very thoughtful way, looking at all of the research...
Who's in charge of this? Who wakes up in the morning and says, this is my priority, I am going to drive this train and make sure something happens today? Who's in charge of it?
I'd say there are a number of people that are doing it. The head of the IACC is Dr. Thomas Insel, who is the director of the National Institute of Mental Health at NIH. But there are multiple. And again, I think it shows, you asked about how important is this to CDC. It's very important. I know how it's important, I can tell you, to NIH. It's extremely important to NIH, and that's why, in fact, there are a number of institutes at the NIH that include autism as part of their research portfolio.
What does it take for us to develop a comprehensive national strategy with real accountability and timelines?
I'd say that, again, the IACC in many ways accomplishes that. If you think that that's lacking, then I would think it's a question really for the Congress to figure out how best to put that together, because clearly, as I think the hearing appropriately reflects, there are a lot of medical issues here, but there are a lot of issues about the lives of those who have autism that have nothing to do directly with medicine per se.
I get that, but where is the dynamism in which that emerging evidence is being challenged and being used in a dynamic concept to hurry to a discovery, at least an advance in this, as opposed to what may be just sort of a, I hate to say it, there's so many different aspects of there, but as an outside observer, I see it as being sort of willy-nilly, and this is the next thing that gets funded today and somebody tomorrow, as opposed to a real focus on a critical path.
Again, I think that there are multiple parties involved in this who are really quite concerned about this, who work in a regular way to try to advance this. Frustration absolutely is there, absolutely understandable. But as Dr. Boyle said, I think, in fact, in recent years we have seen a clearly acceleration in progress in this. Is it sufficient? No. Is it accelerating? Yes.
Well, we've seen an accelerated in diagnoses, so we need to have the same intensity, I believe. Thank you, Mr. Chairman. I yield back.
The Chair at this time would ask unanimous consent that our colleague from Florida, Congressman Vern Buchanan, be allowed to participate in today's hearing. Without objection, so ordered. Okay. Glad to have you aboard, Congressman. Now, my friend from Massachusetts, Mr. Turney.
Thank you, Mr. Chairman. I appreciate that. Thank you for our witnesses and all of the folks that are taking the time to be here today as well. I did want to start by just addressing a concern that my colleague, Ms. Norton, had with what can we possibly do for those children that are aging out, so to speak, of the services on that. We did have in the Higher Education Opportunity Act a couple of years ago a provision that was carried in the House, and Senator Kennedy carried it in the Senate for colleges and community colleges to address programs of sustainability for at least those on the spectrum that were able to be addressed and be helped by that. Unfortunately, in the next iteration of the budget, it didn't get funded again. But I think we could all put some attention on that and deal with some families, at least, on that, helping people have that ability. And I would look forward to others on this committee that might feel that that's worthwhile pursuing on that, and we could do that again and perfect it a little bit, please. Dr. Boyle, you mentioned in answer to Mr. Burton's question that since 2000, thimerosal was removed from all of the vaccines except the multi-vial for vaccines on that basis. Can you answer me why, just as a matter of precaution to eliminate that whole issue, it isn't removed from them as well?
Actually, I said since 2001, and I'm not a vaccine expert, but my understanding, and I will clarify for the record about this, is that the multi-use vials are needed in certain context from an international or global perspective. But I'll clarify that for you.
If you would, just why is the necessity that they're used everywhere? It could be diminished in some way and substituted with others on that basis. I think would be helpful on that. Also, to either or both of you on that, is there a differentiation between incidence of diagnosed autism in other countries that as opposed to the United States? Is it a region specific? Are there other concerns like that, or is it generally the same pervasiveness throughout?
So in most developed countries that do have data on autism, the prevalence has been comparable, about 1%. There was a recent study that was supported by Autism Speaks in South Korea. It showed a much higher prevalence, at 2.6 or 1 in 38 for a prevalence. That was done very differently. It was a community screening program or a study versus a different method that we use here in the U.S. I do want to mention one thing, though, within the context of our monitoring network here in the U.S. The prevalence varies considerably, so there are some states that have comparable prevalence rates to that South Korea study.
So what are we doing to sort of try to determine if there are higher rates in some states or some parts of some states than others? Are there a good number of studies going on trying to find out what's different about the environment in those areas than others, and how is that all being determined and coming out? What are the outcomes of those studies?
So our monitoring network continues to track the prevalence. We're trying to identify children at a younger age, so we have a component to identify children at age 4. We are doing studies to try to understand what's impacting that prevalence rate, both from a community perspective, understanding how children are identified and diagnosed in the community, as well as changes in risk factors, and modeling how those changes in risk factors over time might have influenced the rate.
So my colleague was talking about diet and other family incidents like that. Is there part of this monitoring that entails going into an area with a very high incidence of autism diagnosis and actually interviewing those families to find out what might be distinctive about their experience or their history?
That's a great question. And actually, we have a second research program, as well as many activities that are ongoing at the National Institutes of Health. So we have a research component in 6 states in the United States to do just that, to interview families, to get more detailed information from medical records, to compare families of children who have autism versus those who don't, and get a better sense of what's different.
In what stage are those studies? I mean, how far have they progressed?
So that's called the Study to Explore Early Development. We've just completed the first phase, so we have 2,700 families that have enrolled in that study, and we've started the second phase. So we are now in the analytic phase of that, and really hope to be having data come out in the next year.
And other than a geographic way of identifying those people, are you doing something also with minority and low-income groups to determine why the prevalence is higher there, interviewing subsets of those groups?
So we are incorporating, so our studies try to get everyone in the population, and to get everyone in the population is always challenging. But that's what epidemiology is all about. It's to be representative of the population, so you don't have any bias there. So yes.
Okay. Thank you.
Gentleman yields back. I'll now recognize myself for 5 minutes. Dr. Guttmacher, you're the only pediatrician here today. And one of my other roles in life right now, is, besides serving in Congress, I'm also a grandfather for 7 children, 2 little girls, one 5 weeks old today, and the one will be 4 weeks old on Sunday. So are you saying that somehow that there's a window of the first year that parents should be looking at different behavioral activities in these children to maybe get an earlier idea that the child may be affected?
Yeah, absolutely. We do think the first year and potentially before that is crucial. It's interesting, for instance, that the NIH and others supported a study that was done in San Diego, which involved local pediatricians doing a survey of their patients, a quick office-based 5-minute kind of questionnaire to try to diagnose children with autism at about 1 year of age to see whether this could be done. Not only did that study show that it could be effective, it was so convincing to the pediatricians that when the study was over, and therefore funding it was over, all of the pediatricians in the study elected to continue to do that in their practices because they were so convinced that this was important for their patients. So I think absolutely more and more we want to make the diagnosis early, because then we can get interventions and services to kids and the families in a way that we can make a difference, and the earlier we start them, the better the impact.
Okay. Dr. Boyle.
This is key, since we don't know how to prevent autism, and we do know there's great benefits from early identification. We want to identify children as early as possible, and CDC has a campaign. It's called Learn the Signs, Act Early, and it's really targeting parents and healthcare providers, and it has tools to really help parents as early as 3 months, 1 month, to understand what the appropriate developmental milestones are. So your daughter, your daughter-in-law, really can take advantage of those materials.
Well, my wife and I spend a lot of time with her, so I mean, it would really be
You
important
too.
also.
Okay.
Well, you know,
Yeah.
I'm always holding them, doing something with them. And the older ones I'm reading to, I should be looking for things that I would never been aware of before. Now, I do represent an area that has impoverished rural areas, and I'm sure a lot of the members feel the same way, because we don't all represent just one group of people, but a lot of people. So how are people in the impoverished areas, how do they get access to this? How do we get to them? How do we give them the opportunity to find out what it is that they need to know also? Is there a method that, I keep hearing people, they can go online. Well, you know, the area that I represent, there's not a lot of people that can go online to do this. So,
one thing I think neither Dr. Goodmacher or I brought up today is we represent two agencies within the context of HHS. And there are others that are represented in the Interagency Autism Coordinating Committee that are whose voices you need to hear about too. So the Health Services Resources Administration focuses on training physicians in rural areas to really try to target. And then our colleagues in the Administration on Developmental Disabilities also do work here, Department of Education. So there are there's a lot of work here, and you're just hearing really from the two of us. And the IACC is really trying, and I know it has its challenges, but it's really trying to bring together all of those voices in the Federal Government in a coordinated way, so that we can really help everyone, you know, really be the group that reaches out to all.
okay. Doctor, do you have any follow-up?
I would just say that there are various regional approaches. Before I came to the NIH a number of years ago, I was the only medical geneticist in the state of Vermont, rural area, and saw numerous families and kids with autism. And that was part of a regional network that tried to approach the questions, the particular challenges of providing both good diagnosis and good care to kids in rural areas. It's a difficult challenge, as it is in any area that has barriers to access, be it rural or urban. There are various kinds of government programs that try to do that.
No, and I thank you. Dr. Boyle, anything on the horizon at all, anything you see coming that could be a cure?
Again, we've been focusing on understanding the preventable causes versus the cure part.
Okay. Well, I want to take this opportunity. Mr. Burton and I share an awful lot of passion for a lot of different things, but we're both grandparents. I've often said, if we could ever exchange and take the place of whatever it is that our children or our grandchildren, we would gladly do so. So I thank you. He's departed again, but what a great effort. And I think Mr. Meehan hit the nail on the head. We will continue to pursue this as long as we can. You deserve an answer, and we'll keep working towards that means. Okay, right now, is Mr. Lynch is not here. Mr. Quigley, Mr. Davis, you are recognized, sir, for 5 minutes.
Thank you very much, Mr. Chairman. Although estimates vary, research on the prevalence of autism spectrum disorders suggests that black and white children are impacted at comparable rates, with lower incidences observed among Latino children. Is there consensus on this data?
You are correct. So our most recent data shows that the prevalence among African American children and white children is fairly comparable. The Hispanic, the Latinos, is lower.
Is it possible that lower rates among Latino children reflect a lack of awareness within the community, and that might be the reason?
That could be the case. And the program I was talking about earlier, which was Learn the Signs, Act Early, we're actually trying to target Latino, Hispanic populations, working with our state colleagues. We have all of our materials translated into Spanish specifically to try to do that. So we are within the context of the work we're doing, really trying to impact that.
Dr. Goodmacher, are you in agreement with?
I'm in agreement and would bow to Dr. Boyle and the CDC for their expertise in this.
It has been suggested that children can be diagnosed as early as 14 months old, giving those children and their families the benefit of early intervention and treatment. However, children of color are routinely diagnosed at a later age than their white counterparts. What barriers exists to early diagnosis of all children? And are there any socioeconomic barriers that prevent parents or physicians from recognizing the early signs of autism among children of color?
I think there are issues of access to quality care, having access to longitudinal care, for instance. The pediatrician or family physician who sees a child, the same provider seeing the same child over time, can more easily pick up lack of appropriate developmental progress, et cetera, than a physician who is, or other healthcare provider who's seen the child only for episodic care. So I think some of the questions of access, et cetera, no question, for diagnosis is principally made in a medical context. There are issues of access here.
So if a family did not have, say, primary care physicians for both themselves and their children, then it is possible that there might be a later diagnosis than if they had this ongoing care all along.
I think it's possible. Creates, this is, there are obviously many challenges to making this diagnosis earlier would have happened long ago. And this adds, I think, to the challenges for the family, for the healthcare providers in doing that.
Well, let me ask this question. Once diagnosed, individuals with autism spectrum disorders have average medical expenditures between 4 and 6 times greater than the rest of the population. The Harvard School of Public Health has estimated that it can cost $3.2 million to care for an individual with autism over the course of a lifetime. Although insurance covers some of these costs, intensive behavior therapies, often paid out of pocket, can cost as much as $60,000 per year. For families of average or limited means, that means that limited access will also occur to treatment. What level of access do low-income children have to behavior or therapeutic interventions before they reach school age?
That varies by locale, certainly to some degree, in terms of what provisions are based in the community and their level of availability. No question that for any family, even a family of great means, the challenges of appropriately caring for a child with autism are financial challenges along with the other challenges they represent. For those of lesser means, clearly the financial impact can be even relatively greater.
Are we making any real progress with that issue?
I think we're making progress. Again, it's frustratingly slow, but we're making progress in terms of coming up with more interventions that make a difference. And ideally, one wants to have an array of options for interventions, because different interventions will be more successful for one individual, for one family than another, but also that access to them will vary, so that it's one of the reasons for not saying, gee, we're happy we have interventions, but say instead, well, we've made progress with interventions, but we clearly need to develop more.
Thank you very much. I yield back, Mr. Chairman.
Thank the gentleman. Now the gentleman from Florida, Mr. Posey.
Thank you very much, Mr. Chairman. Dr. Boyle, my predecessor, Congressman Weldon, was a well-respected, competent medical doctor, and a great deal of esoteric expertise on this subject that I'll probably never have. But I gleaned from him some certainty that he felt thimerosal in vaccinations definitely was a contributing factor to autism. And I read not very long ago an article that it said until the wonderful people like us introduced vaccinations to Africa, the African children basically were autism-free. They never heard of autism, never had a case of Down. Are you familiar with that? Have you ever heard that before? Okay. I wonder if the CDC has conducted or facilitated study comparing vaccinated children with unvaccinated children yet. Have you done that?
We have actually done a number of studies looking at the relationship between thimerosal vaccines and autism and other developmental disabilities. And there have been, since actually over the last decade, there have been numerous studies looking at the relationship between vaccines and aspects.
That the CDC conducted?
Some of them were conducted by the CDC, others were conducted by
How many would you say, would you estimate?
I would actually have to check what the specific numbers, but I know there were two, one large study looking at various neurodevelopmental disorders, and the second one that focused specifically on autism. And those were fairly recent studies.
Would you see that my office gets a copy of those, please?
Of course, I'd be happy.
Do you believe additional study would provide useful data in assessing the safety of childhood vaccines?
The IOM has evaluated this issue back in 2004 and again most recently in 2011. And their conclusion, again, it was not just looking at the work that was done at CDC, but with the total body of evidence, was suggesting that vaccines and their components did not increase the risk for autism.
My time is very limited here. So clearly, definitely, unequivocally, you have studied vaccinated versus unvaccinated.
We have not studied vaccinated versus unvaccinated.
Oh, okay. Never mind. Just stop there. That was the meaning of my question. You wasted 2 minutes of my time. What steps has the CDC undertaken to ensure the integrity of the research that was performed by Dr. Thorson, who, as you know, has been indicted for misconduct and misallocation of resources?
So Dr. Thorson, who was a co-investigator on a couple of studies that came out on autism, was really just one investigator. And that body of evidence related to vaccines and autism.
All right. Have you gone back to validate the variety of studies he participated in? I mean, you know this guy is a humongous scumbag, one of the most wanted men on earth, and you relied upon him for data to determine whether thimerosal had a negative effect?
So two studies don't conclude a body of work. The body of work that's relating vaccines to autism is a large collection of studies.
You told me you only had 2 studies relating to vaccines, vaccinated and unvaccinated, so you must figure 2 studies must have some weight. Running out of time quickly here. You mentioned that you only have thimerosal and multivial. Why is that?
I was actually going to get that information for the committee.
Okay. Because I would think if they only have it in multivial, if they eliminated having it in all the other vials, there was a reason.
There is definitely a reason, so I was going to clarify that.
Yeah.
There are single-dose vials and multi-dose vials.
And they took it all out of everything but the multi-dose vials.
That's correct.
Okay. How many multi-dose vials are there?
I can provide you that information.
Okay. I've seen a chart that ranks the longevity of the 30 nations with the best mortality rates in the world, starting with Iceland, Sweden, Singapore, and on down. We didn't even make the top 30. We're the 34th. And ironically, we require more vaccinations than any other country that's healthier, has a less mortality rate than us. Do you see any correlation whatsoever, either one of you, to the 34th worst mortality rate and the most vaccinations to the ones with the least required vaccinations and the lowest mortality rate? They also have children that, past age 20 in those countries, too.
There are many factors obviously involved in longevity for any country. The one thing we do know about vaccinations is that they are among the major public health reasons why generations today live much longer than in previous generations. They are perhaps the most successful public health movement in the world.
Nobody's talking about or against vaccinations.
Well, I was just trying to answer.
We're talking about thimerosal in vaccinations.
I was trying.
And multiple, bomb blast of vaccinations in short period of time on very, thank you, Mr. Chairman. My time's up.
I'm sorry, the gentleman's time has expired. Did you want to answer?
No, I think I had an opportunity. Thank you.
Okay, very good. Then the next person, the gentleman from Kentucky, Mr. Yarmouth.
Thank you very much, Mr. Chairman. Thank to the panel for your testimony. Those who know me, and now those who don't, I wear these bracelets every day. These are bracelets that were the brainchild of a young woman in my district who's now 16. She has a younger brother who's autistic. She started at 11 raising money for research in autism by selling these bracelets for $3 a piece. She's now raised over $600,000. Her name's Michaela Riggle. She's already financed a $250,000 study in one aspect of autism. And I raise that not just because I like to brag on her, because she's an incredible person, but also to illustrate the kind of civilian activity that is going on in this field, and it's represented here clearly today. We are here as representatives of the government trying to find out whether there's anything the government should be doing that we're not doing. And obviously there have been a lot of concerns expressed here about frustration in the activities of government. You know, a lot of what we can do is fund things. We do know how to spend money. And we do have this across-the-board cut coming up, so-called fiscal cliff, if we don't act. We're very much dealing with spending priorities. Last year we, for instance, passed a defense appropriation bill that allocated $2 billion more than the Defense Department actually requested. We still give oil companies $4 billion a year in subsidies that they don't say they need. So my question is, if you had another $2 billion or $4 billion, what could you do with it? And how would you spend it?
One thing I would say before I would spend the dollars is I would not want to displace the private efforts, the efforts that you mentioned, because I think part of the reason why autism research advances is the combination of Federal funding, but also having private organizations, advocacy organizations who have research efforts as well. And often these research efforts are, there are many things I mentioned today already in my testimony that are supported both by Federal dollars and by private dollars. And also, of course, the important input of the families, the individuals with autism who themselves inform the research and help shape the research agenda. So no matter what the money, we should keep that partnership. I think in terms of money, clearly, I think as Dr. Bose also talked about, that we can see there are particular scientific opportunities right now in terms of better understanding environmental factors. Many people I know have been concerned that there has been too much focus on genetic factors in autism. I would argue that, in fact, understanding those are very important for understanding the environmental factors, because we know it's a combination of both. So to figure out the combination, it's great that we better, still not fully, but better understand the genetic ones. So now we can focus more on what the environmental factors are, because after all, those are the ones that we can influence and control. So in terms of investments in that, and again, investments in looking very early in life to better figure out what the etiology is, but then also investments in terms of interventions so that we have more effective interventions and more options in terms of interventions. And again, I think more research and more work in trying to figure out how to best have an impact on the lives of those living with autism, both in childhood but very particularly in adulthood as well. So that I think there are a number of areas where we can wisely invest money.
Dr. Boyle?
Well, thank you very, very much for the question.
I wish I could offer you the money.
Yeah. But anyway, we do get requests all the time from states. So we fund states both to do surveillance and to do research. And particularly in the area of surveillance, the state has good knowledge about what's going on within their context, so they can plan for services. They can address some of the many issues that came up today about disparities in diagnosis among racial and ethnic groups. I mean, that would be one of the places we would really like to be able to fund more states. And similarly, to get answers faster. We have worked very hard over the last 5 years, and it's not really we, it's our academic and state partners who have worked very hard over the last 5 years to develop our research base. And we're just at the cusp of actually being able to explore that. More dollars would actually allow us to do work faster and to really be able to put as much energy into getting good answers for all of the questions that we heard today.
Okay. Thank you very much for your testimony.
Thank you. Now, would Mr. Smith from New Jersey.
Thank you, Mr. Chairman, and I appreciate the committee's allowing me and others to sit in on this. And I want to thank Dan Burton for his extraordinary work. He is truly a champion. I sit next to him on Foreign Affairs, and he's a great member of Congress and a great leader on combating autism. Dr. Guttmacher, in your testimony, you state that since passage of the Combating Autism Act, there's been a groundswell of activity suggesting, and I think unwittingly suggesting, that this has been about a half-dozen-year effort. As you may know, I introduced legislation as far back as 1997 that became law in 2000 as Title I of the Children's Health Act that established the Centers of Excellence, the Interagency Autism Coordinating Committee, and really began a robust effort that continues to this day. And, of course, the reauthorizations have been very important. My point is, we've been at this in a comprehensive way for more than a dozen years, and there is a sense of impatience that we all have. Frustratingly slow, I think was the word that was just used. But I want to just make a point. Resources often follow demonstrable need. I know that we were able to marshal huge amounts of money to combat the AIDS, the pandemic of AIDS. And Henry Hyde led the effort. George Bush, it was his idea. And we spent billions in combating AIDS, particularly in sub-Saharan Africa, because the demonstrable need was married up with the resources to try to make a difference. I think it hurts the effort, but we have to be accurate. When the 1 in 88 number was first released, horrible number, terrible number, the Associated Press, Mike Stobbe writes on March 29th, lead, autism cases are on the rise again, largely due to wider screening and better diagnosis, federal health officials said Thursday. Dr. Guttmacher, you were asked in the New York Times article about that question of epidemic, and you said, yes, it seems to be more common, but the jury is still out. The bottom line is you asked two questions rather than perhaps answer it. And again, you've got to go where the science is, and I deeply respect that. But it is now a couple of years later, and I would appreciate it if the jury is still out, whether or not it's just better surveillance, especially in light of what Autism Speaks has discovered in South Korea. The 1 in 38 study that they funded makes it very clear that when you go further into a study, into the weeds in terms of asking the right questions, more rather than less seems to be the case. And I'm wondering if you could comment on that South Korean study. Secondly, so jury out study, if you could speak to that. Africa. I chair the Africa Global Health, Global Human Rights Committee. I've been working on the Foreign Affairs Committee for 30 of my 32 years in the U.S. House of Representatives. We never saw a prevalent spike like we've seen on autism in Africa as we have seen in the last 15 or so years. I had the first hearing ever on global autism, and what we got back from those who testified was that and the WHO backs us up, there are probably tens of millions of cases of autism in Africa, sub-Saharan Africa in particular, and nobody knows why. I was in Nigeria giving a speech on combating human trafficking, and a man came up and told me, he says, you can't believe how many children in Nigeria are living with autism, and of course in a developing country, it is very, very hard to overcome that. It's hard in this country, even harder there. So if you could speak to those issues. Dr. Zaharati, Walter, who's our principal investigator in New Jersey, he is here today. He's a very good friend, a very, very competent man. My question regarding New Jersey, we have the second highest rate. Are the other states just as high, but they haven't done, or the methodology has not been as keen and as effective? Again, suggesting that we have a worse epidemic than some would suggest. Your thoughts, if you would, on whether or not gut flora is a contributor. We know immunity is found in the intestines. There has been, I think, a nexus between the two. There's very suggestive research on that the lack of the gut flora, particularly in women who are pregnant, may contribute, we don't know, to this problem. And finally, and I'm almost out of time, but the idea of, like with AIDS research, having an Office of AIDS Research that can really number out what their recommendations, put price tags to it, shouldn't we have that also in our efforts to combat autism?
Congressman, let me try to respond to all of those questions. Please let me know if I haven't responded to all of them. First of all, I certainly do not want to leave the impression that it's only been in the last couple of years that the IACC has had a role. I know that your long-term leadership of the Autism Coalition made sure that that was put into effect a number of years ago, and I think has long had an impact. I was only trying to emphasize I think there's been, as it's both grown in terms of membership and also I think gotten more experience, it's become more effective with time is what I was trying to say. I think in terms of the South Korean study and the 1 in 38, there are obviously some methodologic issues with that, but there's methodological issues with almost everything. I think it's a very well-done study. Does it show that the rate is increasing? Unfortunately, we don't know because if there was not a precursor study in South Korea, it will be very important and interesting to see a few years from now were that repeated in South Korea with the same rigorous methodology, what numbers they see. Clearly, we know for sure that some of the increase in terms of the rates the CDC cites, and again, I would bow to Dr. Boyle on this because she has more expertise. Clearly, we know that much of that is due to increased and better diagnosis, which is laudable. Whether that explains the whole thing, I don't think that we scientifically know for sure. I think that there's enough of a reason to be to some degree, obviously, this is a hugely important question. To some degree, it's not so important because regardless of the answer, we know, A, that there are environmental factors at play here, and we need to identify them. B, we know it is a common public health problem, so we need to take it seriously. So regardless of whether the rate is increased or not, hugely important question to answer, but in terms of what we do, much of what we do would be the same in either case. I think, for instance,
the time has expired, so if you could just summarize.
Okay, quickly, let me answer the gut flora question because I think it's an important one. It's those kinds of questions. In fact, we obviously know that the rate of Caesarean section is much higher than it used to be. What's the difference between being born by Caesarean section and born vaginally? One of the big differences is exposure to gut flora. What gut flora, what flora colonize the gut of the infant at birth? Could that play a role? We don't know. It's one of those many environmental things that we should be looking into.
Thank you, Doctor. Now we recognize the gentlelady from New York. Mrs. It's nice to have you with us.
Thank you, and thank you for calling this hearing. Autism is becoming a growing epidemic in the United States, and it definitely needs to be addressed. And I want to compliment, really, Congressman Burton for his leadership. He's not here now. I think is he here? Yeah, and for being the chairman of this committee and doing such a fine job. But you have really focused on this, and I think you've made some progress. And I want to thank you for your leadership on this issue and so many others, and express my gratitude to you and how much I've enjoyed working with you. Now, the numbers that he pointed out earlier, that it used to be 1 in 10,000 kids got autism. It's now 1 in 88. And I'd like to ask Dr. Boyle why. And I don't want to hear that we have better detection. We have better detection. But detection would not account for a jump from 1 in 10,000 to 1 in 88. That is a huge, huge, huge jump. What other factors could be part of making that happen besides better detection? Take better detection off the table. I agree we have better detection, but it doesn't account for those numbers.
So just to put it in context, better detection is accounting for some of it. Like
right, I know some, but what other factors? I don't want to hear what other factors.
Our surveillance program counts cases of autism and establishes the prevalence. It doesn't tell us all the answers to the questions as to why.
Okay.
So we are doing a number of studies to try to understand the why. And one of the things that we've looked at, we've tried to look at what's changed in the environment of things that we know are risk factors for autism, things like preterm birth and birth weight and various.
Well, are you looking at vaccinations? Is that part of your studies?
So let me just finish this one. So
no, I have a question. Are you looking at vaccinations? Is that part of you? Pardon me?
So there is a large literature, as I mentioned.
Are you having a study on vaccinations and the fact that they're cramming them down and having kids have 9 at one time? Is that a call? Do you have any studies on vaccinations?
There have been a number of studies done by CDC on vaccinations as well.
Could you send them to the ranking member and the chairman here?
Yeah.
Now I want to tell you a story. We all react to our lives. And I remember people talking about hormone replacement. It's going to save women's lives. You got to take it. Yet every nurse I talked to said, go to the bank, it causes cancer. Every relative that got cancer said they got it because of the hormone replacement. I'm hearing the same kinds of stories on vaccination. I must have had 50 different parents write me or come to me and say I had a healthy child, yet then they had 10, 9, 6 vaccinations at one time, and that child changed overnight and was knocking their head on the wall, and it was a changed child. In fact, I had a family in my office today where the mother broke down crying, saying my child was wonderful, bright, precocious, talking. She took those vaccinations, and the child became very incredibly sick and has never recovered. So I'm interested in any studies on vaccinations and trying to understand that. Now, it used to be that you'd go and get a vaccination. My child never got more than 3 at a time. And in the state of New York, children are recommended to get 6 shots every 2 months throughout the first year of a child. And my question is, why does a schedule of these vaccinations require a child to receive so many shots in such a short period of time? You could plan those shots over a period of time. I'm for vaccinations. They prevent disease. I'm totally for it. But why do you have to cram 9, 6 at one time when the verbal evidence seems so strong from so many people that they had a healthy child until they got vaccinated? And you've got to just listen. You know, I remember smoking. I was on the city council. I sat through so many hearings where they vowed smoking was not bad for your health. It's a common sense that it was bad for your health. Then finally, the Surgeon General said it was bad for your health. The same thing seems to be here with the vaccinations. There's too much verbal evidence coming from parents where they break down. I had a normal child. I gave him a vaccination, and then they came down with autism. So it seems to me we should. I'd start spacing it out. Why do we have to have 9 vaccinations, 6 vaccinations every 2 months? Why can't we do it over 2 or 3 years and space it and wait for the scientific evidence or whatever?
Gentlelady's time has expired.
May she answer that question?
If you could summarize.
Sure. There is a Federal Advisory Committee that determines the vaccination schedule. And the reason, and again, we'll clarify this and get you more information, but the reason they cluster the vaccines is really to try to make sure that everyone gets it. People don't, and again, we're trying to make sure vaccines go to all children. And not everybody goes to the doctor routinely, so they use that opportunity to make sure that happens.
Thank you. The Chair now recognizes the gentleman from Florida, Mr. Buchanan.
Thank you, Mr. Chairman. I also want to recognize Congressman for all your leadership over the years on this issue. A lot more work to be done, but I want to applaud you for that. Let me just focus back on the vaccines. Some of my colleagues have brought that up today. Is it true that we have over 40 vaccines, and I'm not against vaccines, all of them either, but let me just say, because I know there's a lot of evidence that they're good, but don't we get like 40-some vaccines, our children today? Is that the number I'm hearing, upward of 40? Yeah, either the doctors, just out of curiosity.
There's exact number, and it varies somewhat. I think 40 is a little bit high, but
why would it be, just to point it out, why is it twice what France is, 3 times Finland, a lot of these other countries? And I know because there's a lot of people that move in and out of France, a lot of diversity. I just don't understand why our kids are getting so many shots. And I think of my father-in-law on a different standard, just in terms of common sense, where he's elderly, but he's taken 8 pills. They found out that a lot of them have effects and impacts on other pills. And that's why I don't know that we're spending enough time and energy looking at this, where our kids are getting twice the shots of everybody else. And I just have, my sons, it seems like they're older now, in their late 20s, but they might have had 7 or 8. And I'm just going by people that I represent in our area that feel strongly that this has to be looked at in a very, very aggressive way, that if we're over-vaccinating our children. And I'll doctor either one of you.
We know vaccines save lives. There was a recent analysis that was presented at the pediatric meetings in April, and I actually have the numbers from that, where it was estimated that 42,000 lives were saved, 20 million cases of disease were prevented, and $13.6 billion in direct medical costs were saved, and that's for each birth cohort. Again, there are complexities in terms of the schedule. There are complexities in terms of the types of vaccines. And this is all carefully thought out by an advisory committee that oversees this process.
Have they looked at the impact that and I'm not a chemist or anything, but when you put all these drugs or vaccines into children, the impact that these various vaccines might be having in combinations? I mean, here's what I get back to. We've got in 2005, according to Autism, it was 1 in 166 children. Today, it's 1 in 88. We brought that up a couple of times. Boys, it's 1 in 54. They're saying 40 years ago, whether it's true or not, this is what they're saying. I'd be interested in your thoughts. It's up 1,000%. So when you look at 40 years ago, maybe we got 6 shots. Now we're getting 40 shots. Is there possibility of any correlation? Either of you.
I mentioned earlier, I mentioned earlier that there is a body of evidence now, it's accumulated over the last 10 years, looking at the relationship between vaccines and autism. And that was evaluated in 2004, again very recently in 2011, which didn't support an association between vaccines and autism from a population perspective.
Doctor, do you have anything to add to that?
I would agree. That's correct.
Let me ask you the other thing. They're saying that the person in their lifetime, the care cost is $2.3 million. Do you agree with that number for autism? That's the number I got.
I don't have a specific number. I'd be happy to provide additional information for the record on.
But I think it's $2.3 million, and they say that it costs the country. I didn't realize it was to this magnitude, $137 billion a year in annual cost this country for care of autism. Do you agree with that number? Either of you?
Again, I would not have the data to agree or disagree. I know that it's a high number.
Okay. Well, I just want to let you know we've got to spend more time and resources and fix this problem because it's obviously out of control. Thank you. I yield back, Mr. Chairman. Yes.
Thank you very much. You know, I'm just sitting here and I'm listening to all this. There's something wrong with this picture. There's something wrong, right? And, you know, the gentleman, I thought, asked some very good questions. As a matter of fact, the whole panel. When you've got this combination of shots, and you go from 1 in 10,000 to 1 in 88, it seems to me somebody would say, wait a minute, let's put the brakes on this, and at least let's try to figure out whether if I'm giving a baby 9 shots in a day, whether that, I mean, how much impact that's having. I don't know how we, I mean, it just seems logical. I mean, if they gave me 9 shots, I would, you know, I don't know what that, and then I know you said there's a body of evidence with regard to vaccines. Mr. Chairman, I don't know where we go from here, but I mean, it just seems to me somebody ought to say, wait a minute, let's put some brakes on this. And not saying don't deal with vaccines. Just look at, you know, whether the multiple shot situation is causing this. And I wish you could see the people behind you. There are grown men that have been crying behind you, and women crying. And it's just so I just hope that we can. I mean, you hear the frustration coming from here, and I'm just sitting here and I'm just saying, wait a minute. It just seems like somebody would say, is there something, maybe there's an issue here? And if we're going to err, let's err on the side of keeping children safe, even if we have to, you know, do a pause and give 1 shot a day. Thank you very much. I thank the gentleman for yielding.
If I may take a liberty of the chair for a moment, it is our intention to include in future hearings, and the gentleman from Indiana is here, a narrow but specific request, and I put both of you, even though you may not be the witnesses, of the question of drug interactions where the FDA approves individual drugs and individual vaccines, but by definition does not necessarily thoroughly study interactions of any sort that can happen with 1, 5, 9, 20 different ones. That's a different hearing, but it is one that we wanted to talk about because one of the questions that we see every day, and I appreciate the understanding, is that both prescription drugs and non-prescription drugs, when interacted, do things that were not tested by the FDA. So as part of our ongoing relationship with the FDA primarily, that is a series of questions we expect to explore, not because we want to further burden and slow down the approval process, but because ultimately that is one of the answers that we are only now getting more evidence that there has to be a systematic approach to dealing with all of what we put in our bodies. And Mr. Gosar, when he was here earlier, talked about food being something that you can't control, but at the same time, drugs have to be looked at in terms of what somebody may eat or drink in proximity to. So I'm not asking you for any information today, but I did want you to be aware that we have done a number of things with FDA, and we do intend on going down some path related to that, and I thank the gentleman for bringing it up. We now go to the distinguished and patient gentleman from Utah for 5 minutes, Mr. Matheson.
Well, thank you, Mr. Chairman, for holding the hearing, and thank you. I'm not a member of this committee, and I appreciate your allowing me to sit in and participate in today's
Well, you may tell your friends, this is a committee that represents all jurisdictions of all parts of the Congress, so we would be loath not to include people from the other distinguished committees that we often ask the same questions on the same subjects with.
I certainly appreciate that, Mr. Chairman, Ranking Member, and I appreciate the witnesses being here today. We've heard a lot about the 1 in 88 number. I come from a state where it's 1 in 47, and I've heard a couple of other members ask questions about differences in incident in different regions, and I'm one that represents a state that's sort of at the one end of the scale, from Utah. And I've heard a lot about this from my constituents, and I've always been an advocate for responsible funding and research for NIH to try to figure out what's going on with this issue. I'd like to ask both of you if you can tell me, based on your organization's research, have you been looking at these geographic disparities, where a state of Utah is 1 in 47 instead, and can you offer me any information that helps me understand why my state has a different number from the national average?
Well, I would go back to some of the comments I made earlier, in that differences in how states identify and serve children. Since our program, our tracking program, utilizes those sources, those record sources to identify children, and that varies from state to state. And those numbers in many ways are a reflection of that. Some of our states don't have access to education records, and since we are dealing with 8-year-old children or school-age children, and they're served through IDEA and special education, that makes a difference as well.
Can you tell me, though, I appreciate there may be differences in methodology for collecting, but is my state better at it? Is that what you're telling me? Or is there something else going on in my state? Has there been any conclusion to these studies that talk about how things are done differently in different states?
So we are looking at both differences in how children are identified, right, as well as differences in risk factors across states to try to get a better sense of that.
Is there a target date when there may be a result? You say you're looking at it now. Do we know when there may be some answers?
Well, there are some answers. So from the report that we put out in 2008, what we could see is that children who were coming into the system were more likely to have a community diagnosis, so their community physicians are more likely to be aware of autism and coming into the system. And that's changed over the 10 years that we've been monitoring.
But I understand that there are differences. I'm trying to figure out, have you validated that that's what's going on, whether there's a 1 in 47 rate in Utah? I'm just trying to figure out why the number is different in my state.
One other example is that we are actually doing, we're not doing, Autism Speaks is funding a special study in South Carolina. So using one of the ATOM sites. They're looking at it in a much more in-depth way to see, in fact, is that number in South Carolina low? So again, it's a puzzle, and we're putting all the pieces of the puzzle together that way.
Yeah, look, I'm not a statistician. I just see a big difference in numbers. So I think it would be helpful if we could understand why that number is different. In my limited time, I'd like to ask one other question. Can any of you tell me about any new therapy approaches that are emerging for effectiveness in treating autism?
There's certainly some therapies in terms of behavioral interventions and other kinds of things that are emerging, that are being developed. In terms of something like a medical therapy, I think we're much farther away from those kinds of interventions, though one would hope that eventually we would have those to offer as well.
Thank you, Mr. Chairman. I'll yield back.
I thank the gentleman. Would the gentleman yield his remaining time to Mr. Burton?
Thank you, Mr. Chairman. I just have one question. Why did the FDA and HHS take thimerosal out of all the children's vaccines except just the one or two or three? I mean, I'd just like to know why they took the thimerosal out if there was no problem and leave it in just a couple.
I think neither of us are vaccine experts, and we'd be happy to look into that and provide additional information.
Well, I'd like to have an answer, because I think most people would really like to know. Thank you.
I thank both of you. I thank you for agreeing to answer that for the record. And by unanimous consent, I allow Mr. Posey to ask one additional question of this panel, then we're going to go to the large second panel.
It's to you, Mr. Chairman. In the course of answering this, one of the witnesses told me that the fugitive doctor had been involved in a couple studies with CDC, and I have information here that he was involved in 21 of the 24 studies, and I would like to submit that to the record, Mr. Chairman.
Without objection, so ordered.
Thank you.
Again, I'd like to thank our distinguished first panel. Again, we will accept additional information for the record. If I know you've been in front for a long time, I might suggest that you take advantage of our conference room in the back and leave when you choose to, but if you can stay for a while and watch it on the monitor, it may help you in additional items for the record. So with that, we're going to suspend. We're not going to leave the room, and if the clerk would please change over for the next panel so we can get started immediately.